My task today is to talk on diagnosis of drug-induced liver injury and herbals-induced liver injury. So why is drug-induced liver injury important? It's important as from the patient's point of view because it leads to tremendous morbidity as well as mortality. And I know at least from some centers in India that it's probably the most commonest cause of liver transplantation for acute liver failures, not all diseases, but liver failures. The doctors per se, you give it with altruistic motives, but if there is a problem or adverse reaction, you're exposed to liability risk. It's the most common reason for termination of drug development of an otherwise very promising drug. And again, it's a single cause. Liver injury is a single cause of withdrawal from the market once it is introduced into the market. Now, the important thing is to consider drug-induced liver injury and whenever you see any raised AST and ALT, with the rising tide of AST, the rising tide of non-alcoholic fatty liver disease, you find that at least about 1 to 10% of common population has AST and ALT. If you have AST ALT, which is trivial, you have DILI is common. If you have an AST ALT more than 10 times, you find in this study, this is the third commonest cause of liver injury. AST more than 20, again, after ischemic and biliary, DILI is the third commonest one. And again, rarely alkaline phosphatase elevation may be an indirect marker of drug-induced liver injury. So at all points in time, please consider the first step as well as the second step and the third step is to consider drug-induced liver injury. Now, this is a beautiful study, and I use this slide very often, and I try to simplify it every time. This is a proactive strategy, and the proactive strategy is in this is a centralized daily screening ALT more than 3 times upper limit of normal by a biochemist. Mind you, these are just picking up AST ALT elevation. By a biochemist, he picks it up, and then it is reviewed by a hepatologist. So you find that out of 1,400 all cases with AST ALT, 0.5% cases were due to DILI or 7. Which the second one is the standard strategy, and the standard strategy is a patient comes to you, you do the blood test, and then you make a diagnosis. And the referral to hospital, 12 out of 28,000, in other words, 0.04% were DILI. The simple conclusion was a simple proactive strategy identified 12 times more drug-induced liver injury than a standard strategy, thereby suggesting that it's very common in your daily practice. So how do you define DILI? Because increased AST ALT is commonly seen in the general population. So these are the consensus criteria. AST ALT more than 5 times upper limit of normal without symptoms, or in alkaline phosphatase more than 2 times. But if you have with symptoms, elevation of AST ALT more than 3 times with bilirubin, the most important thing is to exclude competing causes. The other most important thing is also the temporal cause, and the cause that you take a drug and after some period of time, and generally it's about less than 30, 60 or rarely 90 days. And again, most importantly, you have to rule out all competing causes and also concomitant drug. And again, what happens to them in case you are inadvertently, nowadays nobody re-challenges with the same drug, but what happens inadvertently if you have challenged them? What happens to the occurrence of DILI? So the challenge to DILI is that there is no objective diagnostic as well as confirmatory test to establish a diagnosis of DILI. You have hepatitis A, B, C, PBC, everything you have diagnostic tests, but not DILI. So DILI basically relies a diagnosis of exclusion. The common ones are viral hepatitis exclusion as well as common bile duct. And clinical features mimic all kinds of liver disease. So on the left, I have listed all the clinical features that you will probably see in your general practice in hepatology and gastroenterology. The common ones include acute hepatitis, sometimes trivial elevation of AST, ALT, cholestasis, and then even rare ones like sinusoidal obstruction syndrome, nodular regenerative hyperplasia, and hepatic adenomas. And when you see it in a practice, you'll notice that there are common causes, for example, acute hepatic necrosis hepatitis in India, hepatitis A virus, E virus. In the West, it is paracetamol. If you have, again, elevation of AST, ALT, alkaline phosphatase in GGT, you can get it in malaria, typhoid fever, dengue. Cholestasis, CBD obstruction, perhaps is the most common causes. The most common cause is intrahepatic cholestasis of pregnancy. So it goes on like that. There are several other common causes of it. But you'll find that every single pattern can be mimicked by a drug that causes drug-induced liver injury. For example, acute hepatitis can be due to anti-epileptic drugs, paracetamol, INH. You find cholestasis due to androgens, oral contraceptives, and sinusoidal obstruction syndrome, for example, is azathioprine. Now, basically, as I said, so you don't have diagnostic marker. So you need to have some causality assessment method. And this is the one from 1993 that has been used throughout the world. called as RUCAM or Russell-Lukla causality assessment method. And it has 7 domains and come to this domain. And then you give scores to these domains. And then you, depending on how many scores you can get, you can either call it possible, probable, and probable. Possible, and last is probable. Now, these are the 7 domains of Russell-Lukla causality assessment method. The important thing is exposure to a drug. How long, when did you take the drug? When did you get the symptoms? Then what happens after you have stopped the drug? You give certain points to it. An important thing, exclude most common causes of liver injury. The third, there's also get points for re-challenge. But again, this re-challenge doesn't apply to anti-TB drugs because more than 90% of the patients, despite developing significant DILI, do not develop hepatitis. Previous reports fetch it to some points, host risk factor fetches some points, and concomitant medicine actually deletes some points. Now, because of inherent problems with RUCAM, the last few years saw effort by many of these drug consortia as DILI specialists as well as drug consortia to come up with what is known as RECAM. And RECAM stands for Revised Electronic Version of RUCAM. So Revised Electronic Causality Assessment Method. So on the right side, you have RUCAM criteria. On the left side, you have RECAM criteria. And one important change is in the RUCAM, you had AST and ALT elevation risk factors. Risk factors actually fetched points, patients who are older, patients who are pregnant, patients who took alcohol. But in the RECAM or the revised criteria, you find that the risk factors have been eliminated. This is very easily available on the internet. So it doesn't depend on subjectivity when you try to do RUCAM, but as this is more objective. So you try and go on filling up whatever data you have, and then it gives you a diagnostic cutoff. Diagnostic cutoff more than 8 is highly likely or highly probable, and diagnostic cutoff of 7 to 4 is probable. And I have listed in a site where you can go and get these. So I think at some point in time, you'll find that people probably will move from RUCAM to RECAM. So are there any studies that, and so I forgot to mention that many of these important thing is there has to be these cases that have been reported in literature, and this RECAM automatically takes it to the liver tox. So it depends. If there are more than 20 cases, you get certain points. But if you have cases like anti-TB drug, you have lots of patients who have already have that taken and developed DILI, you get much more points. So it's automatically linked to that. And then this is the abstract that we presented last year's ASLD. We probably were the first people. We looked at about 100 cases and tried to compare RUCAM with RECAM. And you'll notice that in conclusion, RECAM judged a significantly greater proportion of patients as probable and highly probable. And you'll notice in the graph that lots of patients are clubbed in the category of highly probable. Whereas the same patients, when you look at RUCAM, you find that they're clubbed in the probable group. So you always want somebody or some attribution as to highly probable, not probable. So again, it worked very well in this, at least in our series. Now I put this slide always, and I find very fascinating. Most drugs that cause DILI have signatures. It's just that sometimes the signatures are illegible. And if you train yourself very well, you can even crack these illegible signatures. And what are the signatures? The signatures could be chronological. If you develop a drug, liver injury within 2 days, it's a certain thing. If you develop maybe after a week, it is a certain thing. If you develop in let's say 15 days after you're taking amoxicillin, clavulanic acid, it's again the drug signature. Biochemical signatures, clinical or immunoallergic signatures. For example, the rising tide of GILI induced liver injury is again linked to immunoallergic or autoimmune like hepatitis. Immunoallergic is, I'll come to the next slide, and histological features. Certain features again tell you probably this could be a particular drug, and sometimes it's a combination. So one of the signatures is drug reaction with eosinophilia and systemic symptoms. These are the classic drugs that are associated with it. And the latest one that is joined the bandwagon is GILI induced autoimmune like hepatitis. Now, I'll take you to 2 cases in just less than 2.5 minutes left, but I can go through it very fast. But just to drive home the point of signatures, and sometimes the signature is just the patient. Looking at the patient helps you. 28-year-old man, no prior comorbidities, dark urine, and these are the investigations. You find that on day 1 it's something, day 10, 2.3 bilirubin, AST/ALT mild elevation, day 2.5, 5.2 bilirubin, AST/ALT about 2-3 times. All viral markers negative, all autoimmune markers negative. Any of the postgraduates, can you tell me what this is? Predominantly cholestasis, AST/ALT mild elevation, everything normal. Otherwise, it looks relatively healthy. Yeah. So this is a man who is a model by occupation, and you can see this was actually given to his photo was given to me by him. So he was taking multiple drugs, and these are the drugs that you can see, plenty of drugs. And see, he was taking tamoxifen citrate, taken by ladies. He was taking human gonadotropic injection, insulin for bodybuilding. So they take all kinds of these drugs and come to you with liver injury. And you see again, and then finally the curd. So it contains a lot of ingredients that can produce liver injury. And there is another fascinating case, again, of a young man, 26 years old. I just took the same shot as put it here. Bilirubin 12.5 actually has very severe liver injury. We did everything, couldn't find a cause. And finally, someone opened his shirt and found that this is what was there. And this was, he said, his wife's tattoo. And he wanted to impress his wife. Guess what happens after he developed severe liver injury? Of course, he recovered from the tattoo, but he couldn't recover his wife. The wife left him. So in causality assessment, last two slides about herbal and dietary supplements, they contain multiple ingredients, contaminated adulterants, ingredient listing must have changed. So it's very challenging with regard to herbal and dietary supplements. And again, that is why herbal and dietary supplement induced liver injury will always remain expert opinion diagnosis. You rule out all cases of causes of liver injury. And then as this slide mentions, even if you use RUCAM, you find that the RUCAM score is only about 38.4% of the times, whereas with conventional drugs, it's about 60% of the time. So the conventional causality assessment methods work very well for prescription agents rather than complementary medicine. So finally, if you have a patient liver injury, history will tell you whether it's hypertension, shock, that will tell you why their AST/ALT is elevated. Alcohol history, if you take it again, it's alcohol liver disease. If you do a seed, especially raised alkaline phosphatase GGT, you can tell you whether obstruction is there or not. You do viral hepatitis, especially in this country, E virus and A virus again. Metabolic, rarely when you suspect it. Autoimmune liver disease, ANA, antinuclear antibodies, and significant titers. Please note that almost 24 to 40% of women have ANA titers of 1:40. So you really high titers, and then you make a possible drug-induced hepatotoxicity. Thank you.